invite our President, Dr. Shubhangi Bhave. She'll be speaking on recent advancement in strabismus surgery. Over to you, Dr. Bhave.
Good afternoon, everyone. As I've said, it's heartening to see these many people in the audience on the last session of the last day, and someone has to do a last session. So that is how it goes. And I'll be speaking on recent advances in strabismus surgery. No financial interest. Now, strabismus surgery has advanced rapidly in last few years. Better understanding of physiology. Yeah. Detecting the presence of muscle pulleys, better visualization of muscle due to advances in imaging has all made this possible. Many new procedures are introduced in the recent times. For the paralytic squints in 6 nerve palsies, we always had VRT of superior and inferior rectus done to LR, but they may have a risk of anti-segment ischemia. So Nishida's partial tendon transposition, a new addition to the armamentarium, has come, and now it's been slightly modified. And so this is the diagrammatic representation, which was also shown by Shreya, that we are taking a non-absorbable suture on superior and inferior rectus about 8 to 10 millimeters behind the insertion, and putting it to a point on the sclera in between, if we are doing it for lateral rectus, in between the superrectus and lateral rectus and infrarectus and lateral rectus. If we are doing it for vertical, as in MED, then we are putting it between superior and lateral and medial rectus and superior rectus. So that is how it goes. This is a small video of Nishida's procedure. So this is the lateral rectus, which is hooked. This is done for the LR palsy. This is the superior rectus muscle. We need to clear the muscle till far back. We are applying 5-0 ethibond. And then this point is taken about 8 to 10 millimeters behind the limbus in the superotemporal quadrant. And similarly, it is done on the inferior rectus muscle. I'll just fast forward it slightly. So this is how, it's a simple procedure, no cut, no cut involved, and so we are sparing the vessels, the ciliary vessels, and so the advantage of this procedure is we can combine it with the, like in cases of MED, we can combine it with inferior rectus recession, or in cases of 6 nerve palsy, we can combine it with the medial rectus recession. So now this is a child having a left eye monocular elevation deficit with very dense amblyopia. He didn't have a good fixation. There was a large hypotropia with exotropia, and left eye had a grade 4 elevation deficit, was not coming up to midline. Horizontal movements though were normal. And this is after the left inferior rectus recession in the left eye with modified Nishidas to left superior rectus. We did it in one sitting. Though there is still residual hypo with exo, but at least we could cover his hypotropia to a large extent. So complete third nerve palsy again is a challenge to every strabismologist. Periosteal anchoring of medial rectus. This fixates the eye in a desired position with the help of non-absorbable suture between the medial rectus and anterior lacrimal crest, and can be combined with supramaximal recession of lateral rectus. So this is the periosteal fixation being done. The non-absorbable suture is taken on the anterior palpebral ligament, the lacrimal crest, and the needle is brought in the orbit. Not a very good quality video. And we tie it to the sclera in front of the medial rectus. And this, of course, we have to combine it with a large LR recession so that we can bring this. And the trick in this is to keep the muscle in slightly esotropic position, so because it is known to drift afterwards, again post-operatively. So this was a complete third nerve palsy following a road traffic accident and an exotropia of about 80 prism diopters with hypotropia. And this is after the procedure, though exotropia could be corrected, but the ptosis could not be corrected because he had a poor Bell's. The other procedures are periosteal fixation of lateral rectus can be done because that's the only muscle which is working. And we can do a Y-split and medial transposition of LR. This was introduced by Taylor and then Kaufman, but the Gogikit's modification is the one which we all follow, where the LR is split and the tendon is passed beneath the superior rectus superior oblique superiorly and inferior rectus inferior oblique inferiorly, and tied 1 millimeter posterior to upper and lower insertion of medial rectus. I think this video of mine is not working. I'll just see if it, no, not working. I saw it in the morning. Anyway, then we come to another new procedure, that is muscle transplantation. This, I'll tell about this as we see the video. Here it is done in sensory cases where the vision is very poor, and normally in esotropias we get a good result, but I have done it in cases of sensory exotropia. This is the lateral rectus muscle which I have put it on the non-absorbable, and this is the medial rectus, and I'm planning about 8 millimeter resection of the medial rectus, and 2 sets of vicryl sutures are applied, and then the medial rectus is then sutured to the insertion, and this segment of the cut muscle is then taken on the lateral rectus, sutured with non-absorbable, and then this is also recessed according to the plan. So basically we are keeping the muscle in front of the equator in this, so we are not doing. That is the difference between supramaximal recession and muscle transplantation. So we do not get any limitation of ocular movements. If you see now this patient who had a sensory exotropia, he had surgery for traumatic cataract and in childhood, and see the poor fixation and large exotropia, and he was not interested in surgery on his right eye, so we operated his left eye doing muscle transplantation, and we could get a good result which has remained stable over 2 or 3 years now. Coming to the loop myopexy, I'm taking 2 or 3 minutes extra because there's no one after me to speak. So loop myopexy has been introduced. As Dr. Sumita was saying, we need to do these in cases of high myopia or myopic strabismus fixus, where the pathology is the displacement of the muscles because of high myopia. The SR shifts nasally and the IR shifts, LR shifts inferiorly. This is the way I do the loop myopexy. The silicone tube loop myopexy I do. The superior rectus and lateral rectus are isolated, and we are taking about 12 millimeters behind the limbus. We are making a scleral groove with the help of a crescent. One has to be very careful as these are highly myopic eyes with thin sclera. And then we take a silicone sling which is put through the superior rectus, through this scleral groove, and then brought out through the lateral rectus. One has to write the paths of superior and lateral rectus, which will correct the esotropia in a good way. So after passing the silicone sling through the sleeve, I tie it with a non-absorbable. Cover it with tenons first and then conjunctiva so as to avoid extrusion of the silicone sleeve. So this is how the surgical procedure goes, and this can be combined with medial rectus recession. Now you see this lady who had a large esotropia and hypotropia of about 80 to 85 prism diopters, and she had a high myopia of -11 in one eye and -16 in the other eye, and there was an abduction and elevation deficit in the left eye. Can it be seen, the elevation deficit and abduction deficit? And then post-operatively, we could get a good correction after doing bilateral medial rectus recession with a loop myopexy. In the left eye, she was practically straight, and her abduction and elevation also improved. So right procedure should be done, and imaging is important because imaging gives you an idea about the position of the muscles. Minimally invasive strabismus surgery, as has been full talk, we have listened by Dr. Subhash, so nothing much to say about it. So to conclude, there are many new procedures are described nowadays, and there are exciting time ahead for strabismologists. It's not the same recess resect. We are indulging in various new procedures for DVD. Each one is coming with good results, and so one has to try so many new procedures. This is our team at Drishti, and I take this opportunity to ask you all to join us at Nagpur on 7th and 8th of December for the annual SPOCI meet.
And you
Thanks.
can announce for midterm also.
Yes, the midterm meeting is at Kozhikode on 26th of May. 26th of
May.
26th of May, Dr. Leela Mohan would be doing this meeting.
Yeah. It was very, very nice presentation, Dr. Shubhangi. And
Thank you.
you're using 240 band Myra, right?
Huh?
For the 240 band Myra.
Yeah, I'm using 240
So
silicone
in that,
band.
even if you have this knot which tie by itself, so you
Okay.
don't have to suture with the
Okay.
sclera.
Okay.
That's very good.
I don't
way
suture
of
this
doing
to
like
sclera.
Yeah.
I pass it through the sleeve
Sling.
and I suture the sleeve and the band.
So if you are not putting sleeve, there is a technique of putting the knots which retinal surgeons are using
Okay.
when they do
Okay.
buckling procedure.
No, it's
It's available.
Yeah,
available.
Yeah, it's available.
It is available.
I
We are
also
using
divide
that.
it into two because it's too long a
Yeah.
sleeve.
It's available.
It's too long. The sleeve is too long, so I cut it into two, so we don't have to pass it through a longer.
Thank you so much. Any question for her?
Any questions?
I specifically, I don't prefer to use glue. Though we use glue just to glue the conjunctiva rather than, we don't have to put the suture on conjunctiva. So I'm doing lots of OSD, so rest of the glue I use to, but not for the muscle. Not for
For
the muscle.
muscles,
As
it
such, it
is
is not seen why to use. Sorry, you want to answer that question? She's asking glue.
Glue for the muscles.
For
I
the
don't
muscles,
think any of us is using. Only for the conjunctiva.
Only for the conjunctiva. और वैसे भी तो बाल ना अंदर चले जाने वाला है, क्या करें?
Now I have been doing plication since last 4 years. I have not found any difference between the resection and plication.
But I have seen that when you do muscle sclera muscle technique, it works much better.
Yeah.
Anybody can prefer any choice, but muscle to muscle rather than muscle to muscle, I pass through sclera. So that
Sharma
works very
sir's video is there on the YouTube. You can. I thank my co-chair, Dr. Subhash, Dr. Shreya, and all the speakers and